So we were told we're going to sit down, and actually, I'm Dr. Kelley, and I'm just the worker. This is the brains. I'm Sean Kelley. So we're going to give this presentation together today, primarily because of the benefits of having physicians and business work together. Sean and I have been working together for 13 years in healthcare. We started in a big healthcare system, designing groups and developing multidisciplinary care systems, primarily in the pediatric space in Austin, Texas. And we generated a lot of learnings from that. During that process, we eventually figured out we were in the belly of the beast. So we've eventually broken out and developed Texas Free Market Surgery. So we're going to go through, I think Sean's going to introduce kind of a brief agenda, go through that, and then we'll kind of trade off on different areas of what we think is important elements for our transition and for other people looking to do this on their own.
So I'm not the brains. I'm the only one in the family who's not a doctor. Now, I couldn't get through the schooling. They did. But on the other side, I bring a complementary set of skills from a career as an entrepreneur and in energy sector that have been brought into medical practice now and brought a new set of eyes. And so I got the pleasure of helping Patrick build several large medical groups within a large system in Austin, Texas. Pat said we developed a lot of surgical practices, and what we learned from that is really the basis for where we interfaced or learned about Dr. Keith Smith and then later on Jay Kempton. I just want to thank both of them because we came last year for the first time, and this group was notably smaller then. I think it's probably twice as big this year, but I was told last year that it was twice as big last year as the year before, so maybe next year.
We're on an exponential growth pattern.
Yeah, and maybe next year we'll outgrow the Skirvin and we'll need a bigger place. So thank all you for guys. Okay, can you hear me now? Okay, so I'll start off with an agenda, and that'll help us get started. Get these out of the way real quick because we got to see the...
We're definitely going to have to switch places at some point.
Yeah. So from the agenda, so we're going to talk about the problem from a multitude of perspectives, but mainly focused on the physician perspective and the business perspective, because that's kind of how we come at things. And then we're going to talk about a solution. And the solution is going to be how we learned from the big system what not to do, and then going forward, what changes in mindset were required to think differently about how to come up with a better solution. And then again, how we came in contact with both Keith and then Jay, and that drove us to where we are today. And then we're going to talk about price transparency. Price transparency, you'll hear a lot here at the Free Market Medical Association. It is the enemy of the status quo. Status quo lives by the opacity of the system today. Next, Patrick's going to lead us through a discussion about quality, which is kind of still, we talk about price transparency. If you look at our website, look at Keith's website and any number of other organizations here who price transparently, you'll see our prices on our websites, which is a big change, but what you still don't see is quality. You can see indicators for it, and we'll talk about those in our talk, but you still don't see a definitive measure for it, and we're going to talk about that today. And I'll talk about some of the early economics that are coming out from that. And then lastly, we'll talk about some key takeaways. Now, if you came today, the title of our talk is Creating a Free Market Healthcare System. Quality plus price transparency equal value. If you came thinking we were going to give you a recipe how to do it, it's not that detailed. But what it is you'll learn today about the concepts that are required and the building blocks that are required to do this based on the regulatory environment in different states. It's going to be achieved in different ways. But we're going to tell you the fundamentals today that'll help you do that. So I'll let Patrick start.
You gotta switch. I'm too short. I gotta be on this side.
Yeah. So I'm what passes for height in our family.
I'm tall on the inside. So the problem from a physician's perspective today is there's just too much complexity, variation, and friction with this, in the system. Physicians spend a tremendous amount of time doing everything other than patient care. There's about 25 plans alone in the state of Texas. Each of them have about 50 different plans themselves, or there's about 25 different payers, and each have about 50 different plans. So up northwards of 500 different sets of rules that physicians have to obey to get paid in the current fee-for-service system. It creates a tremendous amount of friction. There's a lot of administrative burden in the current system. And where there's complexity and excessive administration, there tends to be sin. And the current system is full of sin. Physician reimbursement in real terms has declined since the 1980s in real dollars. But yet we're still asked to do more and more work and more activity. And again, a lot of it is not focused on actual patient care. So it's led to a significant amount of physician burnout. This graph or this table describes all of the different things that goes through a physician's mind on a daily basis within their practice, day in and day out. And it's led to burnout. So I think burnout's probably a very appropriate and good description of the state of physicians today. That is depersonalized, emotionally exhausted, and to a large degree, there's a large sense of low personal accomplishment. So Sean is going to go over the business perspective, the problem as we see it today.
Yeah, and I just want to add that while both my brother and sister are physicians, and they are very good physicians, I have noticed in the last several years a significant rise in their level of burnout, described in those three ways. And most recently, I think Patrick let out last week, he was just like, it's just so crazy nowadays. And it's not because he's getting the fulfilling part of taking care of people, it's all the other stuff. So I'm going to walk through from the business perspective. So the business model, when I came into healthcare, I had a 20-year career as an entrepreneur in the energy sector. I was in a nice place when Patrick asked me to come help him build his medical practice. It was a nice place then, but it was going downhill, and most of it, you know where it is today, and it's a little nice place called Venezuela. And so I was all too happy to come to Austin and leave that. And so if you want more on that, you can talk to me later at the bar. But what I noticed strikingly, and when I talk about providers or physicians, I'm talking generally about most independent healthcare providers. I'm not really talking about big systems. And so to that point, when I got into the business, I noticed that most of the business model was really built around single practices or one or two doctors, but really small business. Now, when you talk to people in the healthcare business on the provider side, a small business is defined as less than $100 million a year in revenue. Well, most people in the healthcare business and provider side think that's huge. That's tiny. Okay, tiny in a lot of senses. But what I also noticed is that practices weren't built based on quality. Practices were built based upon the fit of the doctors, who was going to cover what, who was going to contribute capital, who was somebody nice, things like that. But nobody really thought of quality first and foremost. So there was a lot of variation in quality. And we noticed this acquiring practices to bring into the practice we were building at Seton. There were some practices where some of the doctors were phenomenal, and then others had really bad reputations, but they're all in the same group. Then I also noticed that there was fairly weak business leadership. Now, that's to be expected. Small businesses cannot afford the kind of talent that comes from our major business schools these days, or even entrepreneurs. And then the other thing that I noted was something when we started growing and we got to a larger size groups, the more providers we got, the more resources we got in terms of physician leadership around quality and then scalable cost. But what we noticed is Dr. Toby Cosgrove, who's a cardiac surgeon at Cleveland Clinic and was also CEO there for 10 years, he said that physician organizations need to be 50 plus providers to have the kind of resources and scale that they could afford to build the kind of infrastructure to monitor and improve quality. And I didn't notice that much when I was getting in the business, and it's actually only 5% of providers operating groups that size. The other thing is you're siloed. So each part of the healthcare system is an island unto itself. So it provides a lack of quality of control over quality. So as your patient goes from your office to the next specialist to the rehab to radiology, et cetera, your ability to control that quality is highly variable, and you really don't know it except by anecdote. The other thing is, when you're small, you get picked off by the big guys, right? So you all know you're price takers in a market. So Blue Cross says, the rate today is 110%. You say, yes, sir. If you try to change that, you may have to drop them. You probably don't have enough power. So your contracting is pretty anemic. And then the other thing is one-off interfaces. So every time you interface across these different entities, it requires professional interfaces. So Patrick has to make a call to a practice, et cetera, et cetera. And so it's very costly. Next, we'll talk about the cost structures. So most of these small businesses are unscalable. BIR is called billing and insurance related expenses. In practices today, it's over $70,000 per physician. Now, the interesting part about that is 60,000 of that 70,000 is unnecessary. Why do we know that? We look at other economies where they have less complex systems and they spend on average about 10,000. The other thing is you have fixed overhead. So we all know this a little bit. If you have 2 or 3 doctors in one office, you get to scale the overhead. Most practices are 1 or 2 doctors, so you don't get to scale that overhead. Another thing is, given the complexity, the variation, the friction of the model, you have a lot of people working for you. A lot of people doing a lot of things other than patient care. On average, doctors employ 5 full-time equivalents for support for every MD. Only 1 of those is clinical. The rest are administrative. Now, you do need scheduling people, and you need people to help the patient get through the system, but by and large, we're talking about billing, things like that. So next, I like to call this the fee-for-service tax. So this is a very interesting chart here. If you look at, this is comparing the cost burden to bill and collect revenue across various industry segments. So if you look at the healthcare services, the green line there, or blue if you see it on your screen, is the number of full-time people you need to bill and collect $1 billion. So you look how big that line is. It's over 800 full-time equivalents. This goes to show you just how complex it is to bill and collect revenue in this industry. Now, all the rules that are in place, nobody put them really in place intentionally to make it costly, make it complex. People put them in place with a lot of good intentions. Well, we're going to put a restriction here. We're going to put a pre-authorization here. All of them were intentioned to control the cost to the purchaser, to the buyer. But what we've ended up with is massive gaming. And so for every rule you come up with another set of ways to get around it, and then we layer on top of another rule. And then that's not even taking into consideration all that Washington puts on top of us in terms of regulation. So this requires knowing the problem. We need to take a step back and think about, if we continue to try to improve what we already know is broken, what are we going to get? We'll get the best broken system in the world because we're master optimizers, right? Business and physicians, I'll optimize the heck out of that stuff. I can make the billing process, I'll be the best in class in billing. So instead of 13%, I'll be 11, right? What have I done? Competitively, I put my practice in a better position, but what have I really gained? Not much. Have not fixed the system. So from a fundamental perspective, we have to change the way we look at things. And that change in mindset is what we went through to get to where we are now. But you can't do it without this. And most of you who've made that switch in this audience will know what I'm talking about. So I like to borrow a quote from a movie, The Matrix. So this is what Morpheus told Neo. He said, and most of you will understand this and feel it. You have to understand most of these people are not ready to be unplugged. And many of them are so inured, so hopelessly dependent on the system that they'll fight to protect it. Now, a lot of us are still dependent upon the system. But if you're here today, you're not willing to fight for it. You're willing to fight against it or fix it or tear it down and build a new one. So that's a huge first step. But we're still so dependent. But for all the people that are in this room, and it's a great audience today, there's 99.9% of the rest of healthcare that's not here that is willing to fight to protect it. And we've noticed that in our 1 year of doing this in Austin, the claws come out pretty fast. So if this slide doesn't convince you of the need for change, nothing else today, I say, will matter. The largest generation in history, this is from a book called Catastrophic Care by David Goldhill. If you haven't read it, you need to read it. This is one of a dozen great insights. He's a CFO, CEO, and has lived it. This is the largest generation in history, millennials. Over the course of their career, they'll pay half of their lifetime earnings to the healthcare system. Think about that. And that's based on a set of assumptions that aren't even true. The set of assumptions that David Goldhill used is that healthcare tracked equally with inflation. It has never tracked equally with inflation. It's always been more. So in this, he talks about two types of payments. The visible ones, those are the ones that we see deducted off our paycheck, the premiums, the deductibles and co-pays that we pay for when we access healthcare, the Medicare taxes, etc. But then the hidden payments, the biggest hidden payment is the cost of healthcare that you pay for through your taxes. So we know a local municipality in our part of the state of Texas that spends over $10,000 per year on their employees' healthcare. And it goes up at 6 to 8% a year. You can see where it's going. It's going to bust our country. I think Dave Chase has said it, and I know that we talked about the free digital copy of his new book, but he says, in the movie that he's making right now, says that the healthcare industry has stolen the middle class from this country. So if you look at that, a millennial, if you signed up a millennial today, my son is going to go to college this fall, and I'm going to tell him, you got to get done in 4 years because you got to get out and you got to work for the healthcare industry. Because if you don't, well, dad doesn't have a job. So here's how it's going to work. You're going to get out, you're going to get to work, and you're going to really hump it because of the rest of your life, you're going to take 50% of it. But if you don't, well, then the healthcare system goes away. I can't imagine a single millennial out there that would sign up for that. But nobody knows it. If you get his book, you'll see it's outlined in great detail. And it's a phenomenal argument for some of the younger people who today are advocating a single-payer system. Why? Because you know what? Washington can't fix healthcare. We just changed administrations. We just changed administrations, and we all had such high hopes. Whether they could actually fix it or not is still, it's totally in doubt. But whether or not they could at least fix some of the problems that we know about from the Obama administration, at least address those. But what have we got out of it so far? Lots of drama, lots of votes, but zero.
Lots of tweets.
Lots of tweets. So what does it mean? We have to fix healthcare. So we collectively, now, people sometimes ask me, who's to blame for the mess we're in? Everybody needs to raise their hand. We're all to blame, either as a purchaser, as a patient, as a healthcare provider, as a payer, whatever the case may be. We're all contributed to the problem. And so we have to change our mindset to say we're going to be the solution, not the problem. So what is the fix? So many of you have heard Dr. David Berwick talk about the triple aim: improved outcomes, lower cost, more satisfied patients. We believe the quadruple aim. The quadruple aim adds the one missing part that I think he missed, but I think he would agree with, is more satisfied providers. it's crazy to think that you could get the other three without. If you're gonna push all the pain onto the doctors and the providers, you're not gonna get the other three. So we really need to make this about fixing holistically the whole system, not just the pieces of it. So if we're going to change our mindset, it's going to require a completely new way of looking at competitive strategy. So when I got into healthcare, I noticed that there was a lot of competition, but I couldn't really tell what it was on. I mean, there wasn't a price, there wasn't, quality. I mean, I know if I'm going to go buy a BMW and I'm going to buy a Toyota, I know exactly what I'm getting, and I know what the price difference is, and I get it. I may not be a BMW car owner, I may be a Toyota, but I know that difference and I know the value difference. So in business, we compete on customer value. Customer value is a fancy term for the difference between the benefits that the service or good deliver less its cost. So we know that it needs to be positive, and we also know how other businesses compete is they improve that ratio over time. So BMW drives a better value for people who want luxury, fast cars. Toyota drives better value for people who want cars that'll go longer than we can live and are generally bland looking. I have multiple Toyotas, so just so you know, and I'm okay with that. So there is one authoritative guru on competitive strategy. That's Michael Porter at the Harvard Business School. And I have a lot of business education. Some would say too much, but I collect master's degrees trying to one day measure up against all the doctorates in my family. But Michael Porter has written every book since the early 70s, every important book on competitive strategy. And so in 2005, he published a book based on 5 years worth of work with a mentee that he had, Elizabeth Teisberg. Elizabeth Teisberg had a problem with some healthcare issues in her family, and it gave him an open view into what the healthcare system was like and how crazy it was. So they wrote a book, and if you haven't read it, you should. When I started working with Patrick and the other doctors, the first thing I said was, I bought 10 copies and said, everybody needs to read it. Skip over the part on pharmacy or medical device, but really focus on the most important thing that I think they say. What they say is, there's not a lack of competition in healthcare. There's a lack of competition on what's important. And what is important in healthcare? Patient value. Healthcare must compete on patient value. What is patient value? It's the achievement of health outcomes relative to cost. So you say, what is that? Well, good point. We don't measure outcomes today, and not many people measure cost, and only a few of us are actually publishing prices, so nobody really knows. But we have to start there. So what we've done in publishing our prices is put at least the cost factor out there for buyers. But what we need to define are the patient outcomes. So it's really, really important, because only from there will we know what we need to spend or where we can cut that will not change the current value. So the solution. So this is a new model that we borrowed from Keith and others, and we added a little bit of our own to what we're doing. So we started off with the idea that there's $1 trillion opportunity in healthcare. $1 trillion of waste, which is $1 trillion of opportunity. So with that in mind, what do we know? So Patrick is a very accomplished surgeon. And Jonathan, thank you for the intro on Patrick, but it doesn't begin to describe what he does. And he'll talk a little bit about that later. But
My favorite subject.
yeah. Yeah, we all know. So the point is that he, in his practice, he does very complicated things, but he does a lot of co-cases. So he works directly with other surgeons in really big cases. So he got firsthand knowledge of the quality of surgeons. And so I like to tell people who are not in the business But there's more than skill involved in being a good doctor. So there are the technical skills. But as a really good neurosurgeon once told me, any monkey can be trained to do brain surgery. He's serious. The technical part of it, the skills part of it. But it's the judgment part, the medical judgment, that is the most important factor. And that's what really improves a physician's quality. So what we did was we built a company called Texas Free Market Surgery. We started with what we knew. We knew good surgeons. Then we said, how we link them up with patients? Because patients would like that, right? Quality surgeon, lower cost model, change, less hassles. So what we did was we bring together the top surgeons with patients, and we created a model that reduces hassles and costs and saves money. So if you want to think about it in real simple terms, we looked at today's model, we looked at all the unnecessary costs, we took all those out. Now Keith had done a huge amount of work on that as well, and we learned from him. So we have the advantage of standing on the shoulders of the people that came before us, which is great, but we also added in some of our own stuff. So what do? We created a safe harbor alternative for providers, physicians, facilities. Safe harbor from the craziness that the fee-for-service model presents to them today. So another thing that Professor Porter talks about is a thing called an integrated practice unit. Integrated practice unit, in simple terms, is a set of providers that come together, providers and facilities that come together for the treatment of a condition. And they do that in a repeated way that generates improvement. So if you start at the top, integrated practice units, some of us have seen these in heart transplants, and we've seen it in cancer, and MD Anderson, places like that have these. Then you measure outcomes and cost. Now we measure outcomes, and we also measure cost, but it's at the patient level. Now I can tell you today, when I got into healthcare, first thing I did try to understand the healthcare business was I said, follow the money. So I went to the CFO of a big hospital system we were working at, and I said, who do I talk to about your cost accounting system? He said, oh, go talk to the guy down the hall. A real nice guy. Used to be a nurse, OR nurse, now he's got an MBA, he's an accountant. I go talk to him. I said, okay, so what's your cost accounting system? After about 30 minutes, I said, Bob, I don't know how to tell you this, but that's not a cost accounting system. He goes, yeah, so you know what one is, right? And I was like, yeah. He goes, well, around here, it's called the Medicare cost report. Medicare cost report is something that they have to report to the government. So I call it a hospital system's lovely little fiction about why a Tylenol should cost $34. Because they build up the cost every year and say, this is my justification for my cost. So what we did was we have become experts in doing time-driven activity-based costing, which we'll talk about in a little bit in more detail later. But once you know the costs and the outcomes, you move to bundled payments across care cycles, integrated care delivery across separate facilities, which is what we're doing today, and eventually expand all this excellent care across geography. Lastly, you build an enabling information technology platform to wrap it all around. So what we do by bundling, the doctors don't know this, the facilities don't know this, the medical device makers don't know this, but we're building virtual integrated practice units. We didn't set off with a contract saying, hey, you want to join this integrated practice unit? No, we set out with, do you like this business proposition? And they said yes. And that's where we started. So the business model, and I'll go through this one fairly quickly, but you have to build the business purposely for efficiency. You don't build it for revenue acquisition or the ability to code or the ability to, game the system. You got to build it for cost efficiency and efficiency in delivering high quality outcomes. So the building blocks are really important. You got to select the physicians and other providers based on their quality and their cost efficiency. You also have to select certified and cost efficient facilities. And so that rules out most big system facilities right out of the gate. Why? I don't think they really want to be. There's too much of an opportunity today to get what they need. And then there's smart purchasing. Smart purchasing really refers to the fact that Whenever you negotiate a deal with a company like Stryker or Synthes or Intuitive, none of them want to see their revenues go down, guys. Every single one of them want to see their revenues go up. Why? That's how they please their shareholders. That's how they earn their bonuses. So I can tell you, Stryker's coming out with a new robot. Everybody says, oh, great, now Intuitive doesn't have a monopoly on the market. Well, no, not really. But Stryker, on their robot, you can only use Stryker implants. So just pay us for our $15,000 knee implant and we'll be friends and I'll give you the robot for free. It's called the Gillette razor model, right? Works pretty well. And then the team. Excuse me. The costing expertise is really important. You got to understand cost at a discrete service level. You got to know how much a nurse costs per minute. You got to know how much a doctor costs per minute. You got to know how many minutes you're going to spend with each patient, because that's your cost. Not this, I saw 1,000 patients, it was $100,000, $100 each one. No. There's a lot of variation in there. MD leadership is really important. Process design, in most practices today and businesses in the healthcare services business, don't really understand process design. It doesn't mean you have to get it right the first time. It just means you got to put it on paper the first time. You put it on paper and then you improve it, continuously improve it. So what does this all mean to providers? Our organization and Keith's organization and many of the others that are in this audience that represent free market healthcare systems, we offer an opportunity to independent providers. We offer you what's called a market straddle. So you can continue to operate today in your current business that you may not like, but you do know, and you do know how to make enough money to support your business, make your income. So you don't have to do, I'm looking at these two lovely ladies down here who are direct primary care. There is no way to stand in one system and then go into the other. So they had to do the jump off the cliff method. But a lot of the facilities and surgeons here today and other providers can do this market straddle. They can continue to operate today and then move into the next model. It's easy to implement, it's simple. We have no restrictive covenants in any of our agreements. We offer a much faster sales to cash than anybody else. We have improved outcomes. Why? Because we super select our MDs. We have reduced friction in our model, so there's a lot less cost. The staff love us. The doctors love us. Everybody loves us when we call. Why? Because it's so much simpler, so much easier. And then there's more time with the patient. This is something that we only learned just recently. We've intuited it, but several of our physicians have spoken up now, several of the surgeons, and said, with your patients, I don't have to jump through all the hoops like I do with some of the managed care patients, and my staff doesn't either, so I actually get to spend more time with the patient. So we know in the long run that's going to provide better outcomes. So we organize all the care into bundles. Just real quick, eliminate cost, reduce cost. We do that by building complete products. That is, a total joint for us is from the preoperative visit to the discharge from rehab. Everything that you can possibly imagine that's in it, that's a standard of care, we include. So it's one bill, one price. We negotiate with everybody and come up with that price. So it creates a lot fewer hassles for purchasers and patients. It also improves clinical focus. And so what we do is we keep a little bit and then we share the rest, the savings. Now today, the buyer gets most of those savings, but a lot of them end up sharing some of that with their patients to steer them to people like us. But then providers also make more money. So what do transparent prices mean? Transparent prices means we know our cost, we know everything that goes into a bundle before it actually happens. And so we can build a price from that. It's ground up pricing. We don't look at a market like Austin and say, you know what? The average price for a spine surgery here is $75,000. You know what? If we price it at 70, we get business. So I talk to my TPA friends and say, hey guys, you guys are paying 75? I can get them all day long at 70. They'd be like, well, that sounds great and everything. That's only 5,000. Okay, man, let's make it 74. No, what we do is we do ground up. We take all the cost, make sure everybody in the bundle is making a profit, and then we add on a very reasonable margin. And to that, you see our prices on our website, you'll see they're a lot less than what people are experiencing in the market. Lastly, there's something about the current healthcare reform that concerns me. And it concerns me from the standpoint of a lot of payers want to try to shift, payers or purchasers shift risk onto providers. There's three types of risk in healthcare. There's actuarial risk, population risk, and then lastly, there's professional risk. Professional risk is the only thing that a provider should take on. Why? That's the only thing they have the capability to control. It's the only thing they can be responsible for. So professional risk is where we make our difference. The actuarial and population, that's best handled by people on the insurance side. That's what they should bear. And they're experts at it. And they have stop-loss carriers that cover them in the eventuality of big actuarial risk. So our model does something that has created a great insight for us, which we've actually closed the gap between buyer and seller. So with the opacity of today and the complexity of doing business, it requires a lot of intermediaries to do business together. And what we do by transparently pricing and building a model with high quality from the start is it closes this gap. Why? We're transparent. 2, we have notable quality up front. 3, we offer a fair price. 4, it's a complete product, no hidden bills coming in later. And then lastly, we offer superior service. And people say, what is superior service? Well, the bar's not real high in healthcare if you haven't noticed. So anything better than today, and there are some notable exceptions. There are some places that do a really good job, but by and large, most of us are dissatisfied with the service that we get when we go to a healthcare provider. So we offer a concierge service that leads people through the whole process. It is different than presenting your Blue Cross card. So we need to make sure that people have more or less a Sherpa to get through the process. Price transparency. Okay, what does price transparency mean? You'll hear this a lot. And I love this quote. This came from the FMMA website. It says, real world free market wins. What that means, we didn't live in this strange world called the healthcare industry, if all we did was price transparently, we would win. I can tell you that's false. Not everybody can buy from us. I can put my prices up, and we talk endlessly to HR benefit managers, to purchasers, to payers, and they love the prices. But then they never get a call back. To me, people are too steeped in today's model, and it's too hard to get out. So everybody knows why we're here today. I just wanted to give a shout out to Jay and Keith. Thank y'all. This organization is phenomenal. We started an Austin chapter. We meet monthly, and we love it. And what do we talk about? We talk about all kinds of stuff. We talk about some of the roadblocks. We talk about some of the victories we've had. We talk about real issues. But most importantly, it is a little safe zone we can get together every month and talk among people that you don't have to answer the question, what the hell is free market? So we really believe in all of the principles that are espoused by the Free Market Medical Association. And if you haven't read the website and you haven't read some of the manifestos that are up there, you should. They're good. So the current system thrives on opacity. Transparency levels the playing field. But today, the purchaser still can't go to us immediately. I put this up as an example. If you talk to people in healthcare about bundles, everybody wants to buy bundles, but not every bundle is made the same way. This right here is United Healthcare's spine and joint bundles. It's built with Baylor, Scott, and White. So if you look at their knee, that's probably 2.5 times what Keith's is. It's probably almost that what ours is. And I'm not even sure it includes everything. And their spine surgeries are $30,000 or $40,000 more than ours. But they're doing something. They're putting this out there. So most corporate purchasers say, well, that's great. Good job. So healthcare quality. At this point, I'm going to turn it over to Patrick, who will speak it.
He'll be back. So enough about you. Let's talk about me. So healthcare quality as a physician, this is really from a physician's perspective. Really what I want to start with is how do we measure quality today in today's healthcare system? And how did we get to the point where a little blue access card represents quality to most employees? Most employers will tell you that they will have to try to pry the cold, dead hands off of their employees off this card to get them to change to any other system. Well, essentially because it's basically a corporate spending card. Who doesn't love going to dinner on the owner's account? It's a great idea. It gives you access to really great places. And essentially this is why, with the lack of outcomes, why things like opulent hospital waiting rooms and big fancy technology like Da Vinci have become symbols of quality in the current system. So patients think that having the blue card is important because the blue card gives them access to pretty hospitals with robots. And if you look at within the system, when you want to talk about quality, quality means very different things to different stakeholders within the system. And what I want to do is I want to go through a case, excuse me, a case of mine that really demonstrates. So this little baby's obviously sick. I'm a craniofacial surgeon. The skull in this baby's not growing adequately, so it's putting quite a bit of pressure on the brain. And you can kind of tell that by the look on his face. So when I present this case to a hospital administrator, this is a great case, qualitatively a great case for them. I'm going to use a ton of these little ultrasonic pens and plates to reconstruct this skull and care for this patient. Patient's going to spend a lot of time in the NICU. NICU days are like gold to hospital administrators. And the patient's going to be in the hospital, use a lot of resources, and the hospital's going to figure out how to translate that into quite a bit of income. Every time I do a case like this in the Austin market, the average reimbursement to the actual reimbursement to the hospital is $285,000. From a BUCA payer perspective, perfect case. The baby came to me at birth. I'm an in-network provider. I work in an in-network facility. I got authorization to do the case, so everything just fell directly in line. There was no friction. The patient had a fairly seamless, their card took them through the system fairly seamlessly. And I just want to make a note that essentially the BUCA payers have outsourced quality to the American Board of Medical Specialties. Their only certification for quality is whether you're board certified. Well, in my market, 90% of surgeons are on the BUCA payer plans. That means at least half of them are less than average. In addition, the state boards have essentially adopted the same thing. If you're board certified, that means you're a good surgeon. And we all know that's not true. Now, if you look at my society, craniofacial surgeons, there's not a bunch of us. If you put us all in a room full of mirrors, it'd take us a long time to figure out anybody else was there. So the only thing we could agree on a case like this about the outcomes, the relevant outcomes, is that blood loss is bad. And the reason why blood loss is bad, it's not because it's like a risk to the patient, it's because it triggers a NSQIP event. If you get a NSQIP event, you got to answer to somebody in the hospital, why'd you bleed so much? Well, I took baby's whole skull off. That's why I bled so much. And the funny thing is that in the last 10 years, if you look at my literature, that's the only relevant factor that we discuss in our literature with regard to these cases. And blood loss, you can argue that you can't do the right surgery unless you lose a lot of blood. Babies make all of their blood in their skull, so it's going to bleed. If you look at government quality metrics, basically these are failure rates. So complication rates, mortality rates, readmission rates, these are all this is important information for us to know, but these are failure rates. This is like me going to pick a new car in the market based on which manufacturer has the lowest engine explosion rates, right? Again, important information, but not how we actually want to choose healthcare, and not really doesn't speak to quality. Now, this person does know what she wants. She wants a baby that has the pressure taken off the brain, so the brain can be the best brain possible. She wants the baby to look normal, so he can go to school. And lastly, she wants the baby's skull to be protective of that brain, so he can become a UT Longhorn football player. So the payers are starting to pick up on this quality thing, and they have new quality initiatives out there. And the question is, are they, from my perspective, are they hitting the mark? So I was informed recently that one of the payers has a premier physician program. Premier physician programs mean you're premier, you're really good. So I asked them if that means more money to me, and they said, no, same low rate, but you're just going to get more patients. So fewer vacations. So I've been in Austin for about 13 years, doing the same thing, same practice. So I figured, hey, we do pretty good work here. I must be a premier physician. I feel like a premier physician every day. So I asked them, how do you rate your physicians? What makes you a premier physician? They said, we go to health grades. We just use health grades. I said, oh, that's simple enough. What is health grades? So I looked up. It's 8 questions, 4 of which are based on my staff in my waiting room. And if you've ever seen my waiting room, it looks like a Chinese train station. So I'm not going to get good marks there. The other is about my personality, which, it's good and bad some days. But none of it has anything to do with whether I can treat that patient, cure that problem for that mom. So much to my chagrin, after being in practice for 13 years in Austin, Texas, and I do 450 to 500 operations a year, a lot of complicated operations. I do a lot of operating, right? You'd figure I'd have more than 1 rating. At least I was better than average. So I did what any enterprising physician, young entrepreneurial physician would do. I went to my brother and asked him how I fix this. So he and I came up with, we incited the 3rd most coveted currency in the American economy, Starbucks card. Who would not do something for a Starbucks card? So I just sent out a bunch of Starbucks emails to patients. The Bitcoin and the US dollar. Thank you, sir. I'll get you later at the bar. I sent out a bunch of emails and said, hey, man, if you fill out a couple of reviews on me, I'll send you a Starbucks card. So within 1 week, I'm 4.8. So now I get to work harder. I'm so excited. So at the end of the day, when we talk about quality in healthcare, we have to talk about value to patients. It's the existential reason why we exist. We provide care to patients to restore or maintain functional status or to relieve pain and suffering. That's why caregivers go to work. It's why facilities provide services and why care plans or health plans provide the services that they do as well. Patients don't want health care. They want health. And this guy wants to have a back in good order so that he can deliver beer, which is an essential element of our life. And he can provide a source of living to his family. So at the end of the day, we really need to be focused. Our outcomes measurements need to be focused on outcomes that are important to patients. As Sean mentioned earlier, Elizabeth Teisberg helped write the seminal book, Redefining Healthcare. Fortunately, she's come to join. I'm on the UT faculty. She's come to join the UT faculty in the business school, and we get to interact with her. And if you haven't read any of her work on outcomes, I would highly recommend her work on outcomes. It's very clear. It's very well thought out. She's an excellent writer. So she has a way of putting things into prose very efficiently. She talks about the 3 C's: capability, comfort, and calm. Capability is the measurement of functional status of a patient. Comfort is the degree of relief from suffering, both psychological and physical. And calm is really a measure of a level to which a patient wants to engage society and the disruption that the care process represents to them. How much does the care process, how complex is it, and how much does it prevent them from engaging in life in general? And fortunately, the 3 C's are just as important to employers. Happy employees make a happy, successful business. For every minute that an employee is fully engaged in their employer's activities, the employer is maximizing their revenue. There's 2 concepts out there: absenteeism and presenteeism. Absenteeism, obviously, if you're experiencing health or a family member is experiencing poor health, that's a real thing. Having an employee not present in his business is a really big thing. But presenteeism is the concept where the patient's at work, they're just not engaged. So healthcare impacts absenteeism and presenteeism to an extremely large degree. And this is why we feel like employers are perfectly aligned partners in the revolution of the healthcare system. It's a win-win. It's really a win-win-win. It's a win for the healthcare system, for society. It's a win for the individual patient, and it's a win for the employer. And at the end of the day, the 3 C's represent not only the gains from effective care, but they also represent the level of disruption to life that the engagement of the system has. So I encourage you to look at Elizabeth Teisberg's work. It's what we base our outcomes on. Unfortunately, for every specific procedure, there's not a single recipe. But if you look at these general categories, they apply to all disease processes. A knee replacement to this gentleman over here may be very different to a 40-year-old gentleman over here. Their expectations from the treatment are very different. Their degree of suffering and pain are going to be very different. So success is going to be different to those different individuals. And that needs to be respected, and that's okay. We as providers can still measure that. We can still measure the differences between this process. Did it deliver the outcomes we wanted for this patient and this patient, this different process for this patient? So going forward, I'm going to hand it back over to Sean. He's going to conclude with some of the economics of quality and then give a couple concluding remarks. Thank you.
So, you know now why I wanted him to talk about quality. Because I was at a forum not too long ago at the Capital Factory, it's a startup incubator kind of place in Austin. There's a whole lot of health tech stuff going on in Austin, and Professor Teisberg was there, and there was a hospital executive and I think it was an ACO executive too. And the moderator kept asking questions about how do we improve outcomes? How do we improve quality? And the hospital administrator went to, we got to have NISQIP and we got to have, this government measure and that government measure. And we've got to be able to produce these kinds of failure rates and infection rates. We got to get this down. And then the ACO administrator says, well, we've got to improve the population status. We've got to raise the health of the whole population. And Professor Teisberg said something so striking, because she was really quiet, she's small, she's sitting in the middle. She's trained as an engineer, which is really important to the way she thinks. And the moderator says, well, Professor Teisberg, what do you have to say about outcomes? She said, well, it starts and ends with patients, with people. We're not talking about the providers. We're not talking about the insurance companies. We're not talking about the employers. We're not talking about the system. We're talking about people. And so that was so important. And we miss that so often in this business because we look at how can we globally change things? How can we scale? How can we create technology solutions? We've already now been through the whole cycle of health status improvement by wearables, right? Where has that gone? A lot of money's been spent. A lot of money's been spent. But did it improve outcomes of a specific treatment for a condition on a patient level? And that's why the 3 C's are really critical because they bring it down to a person. And when Pat talks about pain tolerances, we know this firsthand. We get joint replacement patients who do really, really well. And a couple hours after the operation, they're like, I'm ready to go. And they're up and walking. They want to go home. And then we get patients that 2 days later, they're like, oh, I think I still need some pain medication. And they don't have a problem with opioids or anything, but their tolerance of pain is very different. It may be emotional, it may be physiological, but regardless, it's different. And so everything really needs to be looked at. And Professor Teisberg, the way she does this is like an engineer. You measure it at the start, you measure it continuously through the process, and you measure it at the end. What do we do in healthcare if we ever measure outcomes? We usually look backwards at stuff that may be kind of old. We try to use whatever data elements we have to kind of discern through the cloud to figure out where positive outcomes, or more importantly, where are the big outlier bad outcomes. And then we try to make decisions about that. We don't, or if we're even better than that, we measure the beginning and the end. But the only way you can really improve it is to measure it at each successive point. Why? Because what Pat said, the calm part of it, imagine if you're going through cancer treatment. I had cancer. I had leukemia at the age of 10. I was treated at Texas Children's Hospital. I went through 3 years of chemotherapy. It sucked. Bad. And this was before the advent of like nausea medication. So hugging the porcelain god, I got really good at that before I went to college.
He exercised in college as well.
I did, for a different reason. But the point was, the treatment itself was bad. And I had the good fortune that my brother and sister both worked in the same research lab that I was treated in. And they got to do research around what are called late-term effects. So the doctors would give us all these toxins to get you better, only sometimes they didn't know the long-term effects. And this is back in the 70s. So some of these drugs that they give you actually cause worse cancer down the road.
And hair loss continued into adulthood.
Well, and without getting too personal, there's hair loss up here, but it goes everywhere else. So the point is that there are late-term effects from treatments. And so this is what Professor Teisberg and what Patrick was talking about. This is the calm. Is the treatment more painful than the benefit? In some cases, the answer is unequivocal. Yes, it is. My cousin is here today. She's head of PM&R at Methodist Hospital in the Med Center, and she takes care of patients that are suffering from a lot of the effects of their treatments. And so this calm piece is really important to measure. Why? Because what if we could change things during the process? What if we could change up the methodology? Or as Teresa was talking about last night, maybe we could do some proactive medicine on the front that would then reduce some of the impacts of these treatments. So if you don't measure this stuff, you'll never be able to improve it. And we don't today. We only measure the failure rates. So I think it's really, really important. But I'm a business guy, so I don't get to really talk about that stuff, so thank God Pat did. What I'm going to talk about is the economics of quality. So we talked in the beginning about patient value is patient outcomes over the cost to achieve them. And so whatever it is today, improving it should give you competitive advantage in a normal market, which, as Jonathan is very good at pointing out, we don't live in that normal market at all. But the economics of quality that we've come to understand are interesting. And this is early signs. So for some of you, you know about what's called complications insurance. It started in the cosmetic world, and basically it's an insurance policy against some of the complications associated with cash type of procedures. So if I'm getting a cosmetic procedure, what happens if a complication happens? Well, I'm scraping together all my money and I'm going to pay for it, and then a complication happens and my insurance is not going to cover that. So I got to cover that out of pocket. So you buy this insurance and it covers the complications that exist for this type of procedure. So we came across a gentleman who's been doing this for a number of years and has actually written 10,000 policies, or close to. He started off in the bariatric space because that was a cash only until very recently. And he found that people, where he was at Mayo Clinic at the time, he saw that a lot of bariatric surgeons were getting out of the business because people were saving up all their resources to get this surgery to lose weight, and then a complication would happen. And then they would sue everybody because they didn't have any money to pay the bills. And so the bariatric surgeons were saying, "Phooey with this, I'm not going to do that." So he left Mayo Clinic, he was head of their risk department, and started this company. And so what it does is he uses quality information on complication rates at surgeon level. Why? This is something that Patrick will love. When we started off with our hypothesis about quality in bundles, I said, well, obviously the surgeon is important, but you know what? The facility is really important too. And Pat said, no, it's the surgeon. So, okay, from a cost perspective, the surgeon's making all the decisions, but I'll tell you what, I think quality is really important from facility level. And what this gentleman told us is that the correlation coefficient between the quality outcome and the surgeon is 0.91. So for those math majors out there, that's almost 1-to-1. So if the surgeon's not good, it doesn't matter how good the facility is, your chances of a good outcome are bad. So this is how his actuaries price things. So the pricing is based on the underlying risk. First and foremost, you got to understand what the risks for that treatment are. Second part is the surgeon. Can he deliver? Does he have the skills and the judgment to deliver the quality outcome? The facilities, when this gentleman told us this over the phone, Patrick got, "See, I told you so, I told you so." And I was reminded of when we were kids. And
there's a little dance involved.
There is a little dance involved. It's a little Irish jig. It was on the table. What I asked the gentleman, I said, okay, I get it. So you've got a lot of data. I don't have a lot of data, but what about the facility? He said, "Sean, we thought the same thing." But he said, after writing thousands of these policies, what we found is that really good surgeons do not operate in bad facilities. Makes sense, right? So it's not that good facilities don't matter. It's just that the surgeon, where they choose to do the case, does matter. So this pricing is based upon the risk that are inherent in the case, but most importantly, the variance from one surgeon to another is based on the surgeon. And it varies significantly. So as I said earlier, 90+% of the risk are associated with the surgeon. So here's the competitive impact. Let's take an example. So a knee arthroplasty or a knee replacement. Let's look at fictitious surgeon Dr. X. His complication insurance for that case might be $1,500. And then we send the same patient, same case information with Dr. Y, and they come back and say complications insurance $1,000. May not seem like much, but actually, this is really early indications of what a price difference can mean. So there's one of two options here, right? Either Dr. Y can say, I'm going to drop my bundle price, or we as the bundling company would drop our price to get more business. So we wouldn't work with Dr. X, we'd work with Dr. Y. Or we could charge the same $22,000, or the surgeon could, and recoup those gains, but have better quality. In either way, the patient's better off because you're getting better quality care. But the pricing of the risk is going to start to create a quantitative degree of value difference. So, see, we are on time. I think we're doing really well. So here's some of the key takeaways. So what we've learned in building a free market healthcare system is that no matter who you're working with, and your partners in this endeavor are really, really important. No matter who you're working with, change is hard. Change is hard, really hard. It's really, really, really hard when your bank account depends on what you're doing now. So there's a lot of risk. There's actually an existential risk. Ask the DPC. They've already jumped off the cliff. But I said this yesterday, and I'll stand by it. Pat and I say, you can always tell the DPC or they're walking around. You go up and you meet them, you talk to them. You can always tell them, and you say, why? Because they're the ones with the ear-to-ear smile. They're the ones who've made the leap, who have decided, phooey with the current system, I'm going in a different direction. And if you talk to them, it's been really hard. So support them. Most of them are so economically priced. In my employees, we gave them money to get DPC, and even some of them dragged their feet for a while. But I told them, once you experience it, once you experience that relationship with a doctor who knows you and can help you, besides having 24/7 access, and where's Dr. Garrett out here, because he knows about my 24/7 access. Hey, Dr. Garrett, thank you. So in the beginning, we had lots of access. We haven't talked in a while, though. But it's really important, and it's a fundamental change. Now, it's changed for a patient to say, but I have health insurance. Why would I want to spend $30, $40, $50, $60 a month on a primary care doctor? Well, because that person's going to have your record. That person's got a really well-run organization. You can get a same-day visit, sometimes even after you call afternoon. You can always get them on text, and you usually get them on calls. Tell me who in this room has that kind of access to your primary care doctor that you access through a network? Nobody. And your doctor changes quite frequently. Why? One group goes on this PPO plan, the next one drops off the next year. I actually dropped my primary care doctor, and I told him this. He's great. But the last time I got a physical from him, he spent 30 minutes in front of Epic, entering in information. He spent 5 minutes with me. His nurse spent 10. And I just said, I'm really sorry, but I'm done. I didn't know what I was going to do, but then I found Dr. Garrett. But change is hard, so it's changed from every single level within this industry. From patients, how they access healthcare. We constantly get asked, well, do you have a card? Do you want a card? I can give you a card. It's $1. But you want a card? Yeah, I love a card. Okay, we'll give you a card. But why is everybody stuck on a card? Because it is about access. People think there's something special about this access. It's not about access. It's about quality health. But you can't really get quality health unless you get really good health care. So change is really hard. I'll say it again, change is really hard. So the other thing, costing is your sharpest tool. Much to my chagrin, the CFOs in the healthcare industry don't know anything about cost. And it's not because it's not available. Other industries have it. And I'm not talking about P&L cost or even at a detailed level, but it's all comes to a department level. That's how everything's done. And it's sad. But when you have no ability to price to market, you have no need to understand discrete costs and how to change them. You can't manage them. It's a fixed cost. So costing, understanding costing, it's not complicated. Bob Kaplan, who is at the Harvard Business School, and I don't know if people remember the balanced scorecard, but he and David Norton created the balanced scorecard back in the 90s, a strategic tool. But Bob Kaplan, Michael Porter brought him in to help, let's say, improve the adoption of this value strategy in healthcare, because he recognized there was a fundamental lack of understanding of cost. And when we started talking about, when we were still in the belly of the beast, when we started talking about how we're going to price to market, how we're going to reduce our prices when we didn't even know our cost, it just makes you go, how in the world can we do it? And then you talk to everybody in the systems, you can't know that. Or, well, it's too variable. And we all get it when we call and ask for prices, right? It's like, well, it depends. It could be this, could be that. It just depends. And everybody's afraid. But people really don't know their cost. They may know their revenue targets or revenue numbers, but they don't know cost. And what you don't measure, you can't manage. So that's a fundamental business prerogative. Got to know your cost. The next is, it's got to be around patients. You got to focus on patients. If you're going to build any kind of healthcare system, that is the fundamental, most important thing. You have to focus on the patient. And that's from a service perspective, it's from a quality perspective, from a cost perspective. And if you can't know any of those three, know them to the degree you can, and then get smart and learn. And then the last piece, good partners are key. What I mean by that, we've worked with lots of different providers in our market who are interested in getting into this. They say, yes, we've talked about bundling for years and years. In fact, the implant manufacturers are probably the funniest part. You start talking to the big guys, the Synthetides and the Strikers, and they load up lots of Gulf Streams and fly into Austin. Hey, we want to talk. We're bringing the strategy guys down. And, $1,000 dinners later, they're like, oh, we really want to get into bundling, all that stuff. But when you get down to brass tacks, they don't want to. Why? Because they're making too much money today. They're really afraid of underselling anything they're getting high pricing on today. So those may seem like good partners because they bring either business or they bring capital, but you get into bed with dogs, you get fleas, and you're just not going to be able to, you're not going to be able to do it because their true north is just different than ours. Whereas on some cases, when we partnered with people, we knew their true north. They didn't know a whole lot, but we knew where they were pointing, and it was aligned with what we're doing. You can work through the difficulties. You can work through problems. But that fundamental understanding of the need for change, the need to tear down the current system and rebuild it has to be there. If it isn't, it's unlikely these people are going to become a good partner. It's going to be a series of trade-offs. And when we brought value-based initiatives to the big hospital system we worked in, we had things worked out from a strategy, from a financial, from a go-to-market strategy. We had it all worked out. And they said, well, we got to run that by the CFO. I was like, I worked with two of the junior guys in the CFO's office. When they passed it by, it's fine. He said, yeah, well, they passed it by from the standpoint of calculating the cost to build the prices. We have to look at it from the perspective of how much money we're going to leave on the table or how much we're going to cannibalize ourselves. And I went back to him and I said, well, when you talk about cannibalizing yourself, if you thought of it or we thought of it, somebody else can. Just ask Kodak. Kodak had all the advantages of winning in the digital image industry, digital photography industry, and lost spectacularly. Why? They couldn't break free from their existing revenue model. They just couldn't. They were too inured of the current system and the benefits. And they couldn't say, well, we've got billions of dollars invested in chemical plants and paper plants and all this kind of stuff. Sell them if they're a bother. So if you're going to do this, you're going to make this shift from fee-for-service to free market healthcare. Partner with people like us, who our true north is good, or Keith, or Sharif. I saw him out just a few minutes ago. Any of the other healthcare providers that are here that represent free market healthcare. Because our true north is good. If your local hospital system comes to you and said, hey, we're going to do a bundle payment, we want you to be involved. Just remember who's at the table, who's the mark at the table. More than likely, it's going to be you and all the other doctors who are going to say, well, we're going to give you 120% of Medicare and we're going to pay you in 30 days. Aren't you like that, right? Yeah, well, they're going to get the rest. So partners with people who get it, partner with people who are aligned really well with the ultimate goal of what we're trying to do. And that is improve outcomes relative to cost. Okay. So I think we'll conclude with that. Thank you.
Don't go anywhere, because now you're obligated to do questions, and Jay wants me to be embarrassed tossing this block to somebody. First question, I think I see you right there.
Good toss.
Touchdown.
And I was looking into the light when I threw that, too.
First of all, I think you guys are just about this close to getting a real good Tommy and Dick Smothers routine going here. I mean, it could work, I think. Great presentation and hit on everything important. I think I understand the value of bundling versus what you call fee-for-service, but I think, and I don't think this is a distinction without a difference, but one thing I think we have to all understand is that, and you touched on this in your last comments, is that coverage does not equal care, and it doesn't, and access, or what we call access now, is sometimes just a position in the queue. And I think the point I wanted to make was that we're not really fighting against fee-for-service. I mean, what Keith does, what I do as a DPC doc, what you do in Texas is fee-for-service is really I provide a service, somebody pays me for it. What we're really fighting against is fee for coding. Mm-hmm. And I think that's the microeconomic engine that drives this whole thing. And with that in mind and how big of a chunk, when Medicare, for instance, I don't think there's anybody else writing insurance, right, for people over 65 other than maybe critical illness policies. So when it comes to that bridge between the belly of the beast and what you guys are doing, how do you, with docs still participating in Medicare and that fee for coding system, how do you get them from A to B?
So I'll start, and I think Sean will probably clarify. Something like that. Yeah. So, so our model allows physicians to straddle. We don't ask them to leave their group of providers and come join Texas Free Market. They're contractors with us. Some of them are investors with us. Some of them are not. We don't ask physicians for investment. We ask them for their time in being a good doctor. So we send the patients to their offices, and they basically just see a patient just like anybody else. There's just a whole lot less paperwork and hassle. They don't have to submit a bill to us to get paid. They eventually have to submit an invoice, but we help them with that part. So the cost of doing business with us, the hassle of doing business with us is so much less that really within a couple months of a provider being onboarded with us, the staff in the office, we quickly become the best payer for that office. They would much rather be 100% Texas free market than have any bucca payer business. So for us, we do pay physicians well. We pay them relative to the bucca payers. We pay them more in general, and we pay them, and it's a little bit of a difficult thing to kind of say as a blanket statement, primarily because there's no real rhyme or reason to the CPT code system. That case that I showed you of the craniosynostosis, I spend probably 8 hours in the operating room doing it, and it's like, I think it's like 35 RVUs. That translates to about a couple $1,000s worth of income for me. A spine surgeon spends an hour and a half with a one-level fusion, and that's 75 RVUs. So the CPT code system's been abducted by the AMA and all of the politics that are doctors. I mean, just imagine the problem I have trying to get outcomes at a craniofacial level. Throw all the neurosurgeons and the orthopedic surgeons in there. I mean, it's a free-for-all. So it's a political system that doesn't make any sense. But in general, we do pay them better, and we pay them faster, and we're less hassle. So our doctors, DPC is not a great example for being able to straddle. You really can't straddle in that. Just the fee-for-service system is so exhausting and time-consuming. A surgeon can't. And so that's really would be my answer to that. I don't know.
Yeah, I think what Pat was talking about is the nonlinear relationship that exists and the CPT is the front thing we see, but the work RVU is really about tying back to reimbursement. And so there's a nonlinear relationship between effort and dollars. And Patrick just brought up one example. I could bring up 100. But when I sit down with each specialty, I say, okay, so just as an aside, tell me the 30-minute procedure that you reimburse the most. And so for a foot and ankle guy, he says, like, $4,000 for a 30-minute procedure. I was like, so I bet you hope you get a lot of those. Oh, yeah. But there's not many. And we fight for them. But then I said, what's the worst reimbursement? It was like $300. So for the same 30 minutes, there was that kind of variation that existed. And it's for all the reasons Pat mentions, the politicization, and we see this. I mean, it's a zero sum at CMS. What happens? Well, we want to give primary care doctors more RVUs. And I was jumping up and down saying, hell yeah, let's give primary care doctors more RVUs. They're underpaid. This is great. What little did I know, they say, well, we're just going to cut everybody else to give it to them. Oh, and by the way, we're going to cut the people that don't have a seat at the table, which didn't include spine. And we're friends with spine surgeons. It's just, they have a very effective lobby.
Yeah. So at the end of the day, the CPT code system, we use it as a descriptor of procedures. But I think, Sean, one of your best points to physicians when we're in the recruiting phase of the physician is the physician has two things to sell: their level of expertise and time. So for whatever they're doing as a foot and ankle surgeon, for 30 minutes, they're going to get paid the same by us. Mm-hmm. It doesn't matter whether it's this procedure, that procedure, that procedure, what the CPT code is. If it takes you 30 minutes, now we have an issue if it takes you 30 minutes, it takes somebody else 10 minutes.
Right.
And we have an issue if you don't do it as well as this other guy.
Right.
But we're the controllers of quality in our system, so that's another element of quality control. But basically, when a physician engages us, they enjoy our referrals because they know they're going to get paid well and consistently and fast. And they don't have to game us. There's no gamification needed.
Another question.
My name is Fatima Jaffrey, and I'm a DPC doctor here in Oklahoma City. And I, first of all, want to express the incredible appreciation I have for your presentation, because I have known and been a student of Professor Teisberg since 2010 and have sat in classrooms with Porter and Teisberg many times. So I really appreciate what you're saying. My inspiration to start a DPC practice was based on these concepts. So my question to you is that the idea of an integrated practice unit has been developed around and demonstrated itself to be incredibly successful in generating good outcomes for cancer patients and surgical patients. Mm-hmm. We attempted to do this work with IPUs on Long Island in chronic illness, mm-hmm. and where treatment and care is longitudinal over an extended period of time. Physicians are arguably the only stakeholder in our system who understand both the complexity of the illness and the complexity of treatment, but do not understand activity-based accounting, primarily because they're cut out of the steps involved with delivering care. So in the complex system that exists today, my question is, number one, have you seen models or created models of IPUs, particularly that integrate medical specialties across the longitudinal time of care? And how have physicians led that, starting from primary care to that end of the cycle, which is still primary care, integrated medical specialties?
It's actually how we cut our teeth. So you saw the patient with the cleft lip and palate. Sean and I, when we came to Austin 13 years ago or something, somewhere around there, there really wasn't any craniofacial surgery. And craniofacial itself is a multi-specialty complex IPU. It involves surgeons, pediatricians, orthodontists, dentists. He has neurosurgeons.
ENTs.
Yep. So there's a lot of different specialists coming from a lot of different angles. We designed a system within the hospital system where the patient stays in a room and all the providers go around, see the patient. We huddle afterwards. We have conferencing. The care is completely coordinated and very efficient. We kept being told by the hospital system that we just hemorrhage money. And at the time, the hospital system, the outpatient system and the inpatient system were not allowed to talk to each other. There was no integrated finances. So this was a big dog, but you couldn't have all the big surgeries that everybody loves without having the outpatient system. So that's when when Sean and I got into costing, and we try to figure out how do you do this. So we actually costed the entire continuum of care for a bilateral cleft lip impatient was our first example. A bilateral cleft lip impatient from the time of birth to about 18, they get about 8 to 10 procedures. And they have a lot of outpatient care, a lot of orthodontia, dentistry, stuff like that. We costed every day. And then we actually developed some costing software from it. But that's where we cut our teeth on costing. And we realized that there's no way you can interface that world with the current world. If your intent is to try to take fee-for-service and where all the dollars go in fee-for-service and collect them into some new system, it just doesn't work. Too many people have their hands on those dollars. So you have to create a new system. So when we went to the payers, to some of the bigger payers, and we said, hey, 0 to 18 for a bilateral cleft lip and palate, we calculated our true cost of delivery, and this was there with the surgeons, especially me, getting paid really well. I paid myself really well.
Well, he changed the numbers.
Yeah.
You deserve it.
But 0 to 18 was $146,000. When we did a data dive with the Buca payers, they were paying anywhere from $750,000 to $1 million for those 18 years of care. This is all mostly outpatient surgery. So we said, hey, we'll give it to you for double that. And they said, yeah, we're not interested. They just don't have any skin in the game. The more dollars that go through them, and remember the ACA turned them into utilities, right? They're capped at 15% profit. So the more dollars that go through their system, the more they make. That's the only way for them to make more money nowadays. So you have to. So anyway.
Wait, no, let me see if I can address it. So we have not seen any medical IPUs. My point in talking about it is the way to go if you can intentionally design from the start, or you have all the providers interested in delivering those high quality outcomes. What our bundling organization effectively does is create virtual IPUs around specific treatments. And on the population versus actuarial versus professional risk, I didn't get into this, and I should have, is that I was involved in it for a year in a startup all-risk health plan. And so I did all the physician contracting. We contracted 92% of the spend, and it's either through bundles or through capitation. What I learned was striking. Bundling is easier because it's episodic. Capitation is not so easy. But I think DPC are on the path. You guys are experimenting in vivo what a capitation dollar amount is. And so I think if you want to design an IPU, I think having the good partners up front is really, really important because you can do it. The costing work and the measurement and everything is complicated and difficult. It's not impossible, but it's difficult.
Thank you.
All right, well, would you join me in thanking Dr. Kelley and his brother?